So thank you, everyone. Tonight, we're going to look at the management of critically ill adults with COVID-19 surviving sepsis guidelines that were published in JAMA, March 23rd, 2020, and of course, throughout the surviving sepsis portals, and see what has changed from March 23rd to today. The first strategy was starting supplemental oxygen if SpO2 was less than 90%. That was a strong one. The second one is for acute hypoxemic respiratory failure, despite conventional oxygen therapy, the use of high-flow nasal cannula is suggested relative to conventional oxygen therapy, and non-invasive positive pressure ventilation, essentially non-invasive ventilation. And would someone like to respond to that? I know there originally were concerns even stated in this guideline for infection control related to high flow, but can you guys give us an idea where you stand on this recommendation?
I know of no evidence or even anecdotal stuff about this being any different from any other situation, Steve. I think their general recommendations have been for hypoxia and respiratory failure and pneumonia generally, and I don't think they're any different from what's generally recommended. The ICU ROC study that was recently completed showed no benefit of a conservative oxygen strategy in ventilated patients, but I don't think that takes away from the fact that there is potential for harm to be done at high oxygen concentrations.
Well, Steve, I mean, if I could weigh in, I think even going back to number one, I think that we probably mostly all agree that we should probably target an O2 saturation of 90% or greater if we can do that with a reasonable amount of oxygen. I think we're in COVID-19 where the real sort of problems and difficulty with decision-making comes in is when we advance the patient to something like high-flow nasal cannula, and they're still okay in terms of the way they look subjectively and the way their work of breathing is, and yet their O2 sats are in a lower range, whether we should be willing to lower our standards for a minimum oxygen saturation that would demand that we intubate the patients. And I think we've talked about this before, but in New York City, when they were at the peak, a number of our colleagues there had decided and evolved to the point where they would allow people to be on high-flow nasal cannula, 100% FiO2, proning, and still have saturations in the 80s, even in some cases below 80, and not intubate them as long as other things looked okay, including their work of breathing and their mentation. So that's not really addressed here in the Surviving Sepsis campaign or the SCCM guidelines, but I think it still remains a real area of debate.
Yeah, I think that's a real challenge, actually. One of the challenges we always face with the high-flow nasal cannula is when do you make that decision to switch to invasive ventilation? And I think for this guideline, they based a lot of their recommendations on the French study. Forgot the guy's first name, Frat. And we tend to follow the protocol they used with the HFNO, and that's once you've got to an FiO2 of 0.8, that is our trigger to consider intubating the patient. Of course, the challenge is that, of course, if they're on 0.7 and they're working hard, then you probably think about doing it a bit earlier. We always feel that if you wait till they're on an FiO2 of 1, once they're on an FiO2 of 1, there's no room to pre-oxygenate the patient to do a safe intubation. That's always our concern. Once you get to 0.8, you've got a little bit of wriggle room to crank up to 1 and pre-oxygenate the patient for intubation.
So, Matt, would you look at, as well as their saturation, would you look at their breathing pattern? Like if they have a high minute volume, would that maybe distract you, you know, to
If
move earlier?
if they're working hard, that will be a, so when we put someone on high flow nasal oxygen,
Yeah.
and really it's any pneumonia, COVID-19 really is not that different once they're in the ICU. If they're working hard and their work of breathing isn't relieved by high flow nasal oxygen, then we will intubate that patient, even if they've not hit the FiO2.
Yeah.
I would agree with Matt. Our practice is generally very clinically based, that if the person is working very hard and once we are going above 0.7 to 0.8, and we haven't touched on an improvement, a significant improvement in the saturation, we would stand by and think about doing an intubation and having a discussion with the patient or the family.
Yeah.
Matt, I think you raise a very interesting point about the difference between hypoxemia, which, you know, the FiO2 is really controls the hypoxemia, and the work of breathing. And so, and even at a low oxygen strategy, if the patient's working hard to achieve their minute ventilation or to achieve the oxygenation, then that's an indication for intubation ventilation, irrespective of their saturation status. So I think we separate the two things out. There's CO2 retention and work of breathing, and then there's hypoxemia, and that they are very often very different in some patients. Very, you know, it can be hypoxemic without increased work of breathing, which has been described in COVID quite a bit, and the other ones where their work of breathing is high, but their hypoxemia is not the issue. So, the Pratt's study was in hypoxic respiratory failure, not in type 2 respiratory failure. It was patients who were primarily hypoxic rather than anything else.
Mm.
The third recommendation was for adults receiving mechanical ventilation who have ARDS, that we would use low tidal volumes, 4 to 8 ml per kg, typical, and is recommended and preferred over high tidal volumes. So that's something I think we can talk about. Also, targeting plateau pressures of less than 30 is recommended. And then this one is kind of interesting. Using higher positive end expiratory pressure, higher PEEP strategy over lower PEEP strategy is suggested. So I think, I imagine you guys have some comments in that area. But again, the low tidal volume strategy, the keeping the plateau pressures below 30, the driving pressure strategy, and then of course the use of high PEEPs versus low PEEPs. So,
so I suppose the only controversial thing there is the PEEP, and I think I understand why they're suggesting high PEEP over low PEEP. But it's very difficult in a guideline to distinguish the different types of physiology we see in our ARDS patients. And, you know, setting PEEP physiologically is probably the best way to set PEEP. But when you're trying to draft up a guideline that's going to be used everywhere in all centers, and some people following it may not be intensivists and will have different ranges of experience in managing ARDS. I can understand why they're recommending the high PEEP over low PEEP, but I think probably all of us here will recognize that there are situations where that could potentially be harmful, particularly if you've got a low elastance type ARDS and you're chasing the PF ratio with PEEP. That's a situation where you could potentially, that particular recommendation could potentially get you into a little bit of trouble. But provided the providers recognize that situation, then I think it's it's a sensible guideline.
And I think in all fairness, they do use the weak recommendation for that. So it is a weaker recommendation, whereas they do acknowledge moderate level or strong recommendations for targeting the plateau pressures of less than 30 and the low tidal volume strategies. That seems to make sense. Anybody else have any thoughts on that set of ventilator strategies for COVID number 3? Okay.
In fact, though, Steve, I was going to say those recommendations are probably no different to any other ARDS ventilation strategies, really. I mean, low tidal volume, acceptable PEEP, whatever that may be, keep the pressure as low as possible. It's all, in a way, quite common sense, right? Like Matt said, the only controversial point is setting PEEP, because that's sort of like a grey zone for everybody, how much PEEP we should be setting. And everyone has a happy zone that they believe is the right zone. I just sort of feel sometimes in these measurements, like Matt said about the elastance, even though it's a recommendation. Like in the field, you would say too, you should have a feedback of, say, compliance or something else to help adjust the ventilator. I think just having numbers sometimes isn't really always a solution. Like I said before, do we have permissive hypercapnia for using very low tidal volume, 4 mils per kilogram? So people do they try and make them normocapnic by having a rate of 30 breaths or 40 breaths per minute and causing more harm? It's all very vague. I mean, what do you think?
Yeah, it's also interesting when you get into I don't think the guidelines touched on permissive hypercapnia, but if you're going to be down to 4 mils per kg ideal body weight, which some patients may need, of course you're going to have to tolerate an elevated CO2. But what I've found goes hand in hand with that is if I'm down to 4 mils per kg and my CO2 is rising, I then have to be a lot more aggressive about often these patients have a concomitant metabolic acidosis.
Right.
And I find that when I'm down to those tidal volumes, I have to be a lot more aggressive about managing the metabolic acidosis, and will often end up starting CRT early in these patients, because you just, to tolerate the CO2 without a crazy low pH, end up having to start dialysis. But then, of course, I'm giving bicarb back to the patient sometimes, which can make things a bit more awkward.
Ross, what do you think?
Permissive hypercapnia, yeah, I don't think this is a recommendation, but I would use it. And like Matt, I think we can tolerate a reasonably high CO2 for a while. I'm fairly relaxed about the CO2 going up even to 100 in the hundreds. And I think during H1N1, we certainly saw that happening. So I'm probably a bit more relaxed about permissive hypercapnia than most people. On a ventilated patient, of course, it's easy because you can control it. Yeah, I mean, I'm not surprised they don't have a recommendation, because there's no hard evidence for its benefit or otherwise. So, and with ECOR, I can understand there is a different way of getting rid of the CO2. Whether that is of benefit is a different issue.
So the fourth strategy for adults receiving mechanical ventilation who have moderate to severe ADS is prone ventilation for 12 to 16 hours is suggested over no prone ventilation, and using needed neuromuscular blocking agents instead of continuous NMBAs infusion to facilitate productive lung ventilation is suggested. Both of those are listed as weak recommendations.
So the proning appears to be beneficial from anecdotal descriptions from other places in COVID, and I'm not sure if it's beneficial to everybody or whether it's beneficial to those that have lung collapse in the bases where it was thought to be useful. So I've got no experience with doing it in COVID at all, but I can understand why it would be useful. The muscle relaxants, again, I don't think there's certainly no trials that show benefit in COVID. There was the original French group of studies that showed benefit in general ARDS, and you can understand that. I think as a aside, if you've got a unit that is being perplexed by the amount of work that's going on, paralysis and heavy sedation along with it would be a good way to control these patients on sometimes less than adequate ventilation strategies, rather than trying to have them awake and coughing and fighting, where it would challenge the average ICU clinician, including the nursing staff. So I think there may be benefits other than physiological benefits to paralysis and having control.
Do you think before the Rose study, the paralysis recommendation would have been stronger?
Yeah, I think so. The Rose study, of course, there were some issues with that. In particular, they were delayed the onset 48 hours before they started, and a few other issues that there were methodological issues, not problems with the study's integrity, but just the protocol. And I think we're tending to use muscle paralysis more, and we're using it very early on. And as Jeff said last week, often one dose or a dose over the first night, and then you don't need paralysis much more after. They don't appear to need it. Now, there's short-term benefits too. There are hypoxic and synchrony benefits, not long-term outcome benefits. And I think there's a significant difference between those two parameters. Yeah, paralysis is useful in the short term to give you synchrony. It'd be nice to think it gives you a long-term benefit as well. And that's what we're trying to achieve.
But also, I think the challenge with any paralysis study is generally the outcomes that are measured depend on what you do after you've paralyzed the patient as much as whether you paralyze them or not. Right? I think that's, if you paralyze someone for 48 hours and then you wake them up and put them on pressure support before they're ready and they're fighting the ventilator, the paralysis isn't going to help that patient. It's in many ways it's what you do after the patient's paralyzed that has a big impact on the outcome that most of these types of studies measure.
Yeah, man, we usually ventilate them after we paralyze them. It usually helps. If you're not doing that, the outcomes might be as good. We've just had, interestingly, in the last 24 hours, an issue which we believe is COVID related in a funny sort of way, that our rock uranium supplier has changed, and we've had a batch of rock uranium which we don't think works. We've had 2 or 3 incidents in theatre where there's been no paralysis at all, and we've noticed in ICU some of it has been very, very short, and so we're not sure what the problem is, whether it's a batch or that there's a new provider which has been forced on us because of needs for a different provider than we previously had of rock uranium. So that's an issue. I don't know if anyone else has experienced that, but basically a large dose of rock uranium failed intubations because of no paralysis at all. So we were using, with our planning, we decided to move to pink uranium because we knew we could get some. It's a good old drug. It's a great ICU drug, a terrible anesthetic drug because of its long-term activity, but a great drug because you give one dose, you don't have to worry about it for a while, and that suits my concentration span. So we decided that would be a better drug to use for paralysis, not necessarily for outcome, than the shorter-acting atracurium, rock uranium, bicuronium. I'm not sure what other people are using. We don't have a cis-atracurium here. We have atracurium.
Yeah, we use atracurium. We don't have cis-atracurium. Yeah, we faced a potential atracurium shortage, which has now been resolved. But for a while, we were fishing around trying to decide on alternatives. Actually, pancuronium didn't come up, but actually it does make a lot of sense.
Yeah, we use cisatracurium and sometimes decuronium. Haven't used pancuronium in about 30 years, but used to use it quite a bit. We so far haven't had any shortages, but it seems like every other week there's a potential shortage of either fentanyl or propofol or Versed or any of the other sedating drugs. So it's a moving target. Well, and I think that's what that's telling us is that number one, at least in the United States, there are a huge number of mechanically ventilated and therefore sedated patients that are consuming an enormous amount of drug. And also, I mean, my own just anecdotal experience is that in the COVID-19 patients, they're requiring, in some cases, a lot more sedation, higher doses and more drugs than what we have typically expected to use in patients with comparable ARDS. And I don't know if that's unique to it or just our impressions. But I've never used so much paralysis than I have in the last 3 months, 3 or 4 months.
I will go through my data carefully to see whether we have had an increase in the amount of usage of sedation and what types. But our clinical impression was that we didn't face enormous extra difficulties in this area. We also did not note any changes in our usage of rocuronium, which is our primary drug. We also have atracurium available. And pancuronium, we have stopped using it. In fact, we don't have a supply now because I think there was very little demand. And we haven't used it in infusion because it's got a very steep dose response, and therefore the wearing off time will be very prolonged if we try and turn it off. Have to wait quite a bit longer for the patient to be able to resume spontaneous breathing. So we don't use pancuronium.
Okay, and their fifth ventilator strategy, the 3 statements. For adults receiving mechanical ventilation who have severe ARDS and hypoxemia, despite optimizing ventilation, a trial of inhaled pulmonary vasodilator is suggested. If no rapid improvement in oxygenation is observed, the treatment should be tapered. So kind of a interesting one. And the use of lung recruitment maneuvers intended to open otherwise closed lung segments, such as 40 centimeters of inspiratory hold for 40 seconds is suggested over not using recruitment maneuvers. But they did say that using a staircase incremental PEEP recruitment maneuver is not recommended. And then finally, the use of veno-venous circulation for extracorporeal membrane oxygenation or referral to ECMO is suggested if available for selected patients. So those are 3 interesting statements, and I'm sure we'll have some dialogue over this.
Well, you know, my commentary on the whole slide would be that we're in the realm now. All 3 of these are weak recommendations with low quality of evidence. And so we're in the realm of expert opinion or anecdotal use. Obviously, I've done all 3 of those things from time to time and still occasionally do. And we're an ECMO center, so we apparently believe that in selected patients it's of some value. But as I'm sure all of you know, the hard scientific evidence for benefit from any of these 3 things is lacking, although you might maybe have a stronger argument for ECMO than the other 2. Nevertheless, if the question is about inhaled vasodilators, we use it a lot. We use it just because of the availability at the facilities that I work. We use inhaled nitric oxide. And just like everybody else, and just like in the literature, we see almost all patients that we use it in have some beneficial effect on oxygenation early on, but it doesn't last very long. And then we're faced with the problem of tapering it off. And, you know, I'm worried about the potential for toxic effects from that. It's just kind of hard to know that in an individual patient, but obviously no randomized controlled trial ever showed a benefit in terms of the real outcome of interest.
Yeah, we tend not to use inhaled nitric oxide in any of our ARDS patients, and not been using it in COVID-19 either. We you know, I have experience of using it and have seen some improvement in oxygenation. Again, it's never felt like an intervention that makes a big difference for the patient. And then, of course, with the literature not showing any benefit, it's something we tend not to be using. There's this sort of emerging concern of renal side effects of the inhaled nitric oxide.
Yeah, and it's probably not even mentioned in publications, but one of the, I think you could call it a side effect that we're experiencing here in San Diego with inhaled nitric oxide, and it appears to be fairly common in the Southern California region that people use that as sort of a salvage technique in ARDS and especially COVID-19, is that when the time comes to refer a patient to an ECMO center like we are, if they're now on inhaled nitric oxide, the bulk of the machine and the technical problems with transporting a patient while they're actively on inhaled nitric oxide becomes it becomes a barrier to transportation. And yet you can't take a patient from 40 parts per million, as the patient that we were referred 2 days ago, 40 parts per million of INO. If you just turn that off, now once they're on it, then it's a problem to turn it off because they tend to deteriorate fairly quickly. So it may not make a difference in their outcome giving it to them, but if you give it to them and take it away, it may precipitate a crisis. So it's almost been a negative in the region.
Dave, I agree with, and I agree with you. And our experience is exactly the same with generally we stopped using nitric oxide because although it improved oxygenation, we couldn't ever get the patients off it in a meaningful way. So we've stopped using it for any indication. I know the neonates have some evidence of its benefit, and they do use it. We don't at all now. We had a ventilator that delivered it quite nicely in controlled, metered fashion, so it wasn't a problem on delivery, but we didn't find it useful and it stopped using it. So yes, as a rescue, you'd try anything, I guess, but not. I wouldn't recommend it as being a first line response to hypoxemia.
I think also the ECMO referral issues that Dave mentioned, that also, you know, what the recommendations are a bit vague on at what point do you refer to an ECMO center, because you do have to consider the stress of transport and whether you have whether the ECMO center has a capability of retrieving the patient on ECMO, and if they don't have that capability, you really can't. It's almost like you can't wait till the patient needs ECMO before you make the referral, and I think that can be quite a challenge for some centers, particularly probably in the US where you have much higher distances for your transfers.
Yes, I agree.
I'm kind of interested in their second statement. The use of lung recruitment maneuvers is suggested over not using recruitment maneuvers, which I think we would all agree. But the use of staircase incremental PEEP recruiting maneuvers is not recommended, and that actually is listed as a strong recommendation. So you guys have any comments about that, the use of lung recruitment maneuvers versus not, and then avoiding the use of incremental PEEP increases, recruitment maneuvers? is not recommended?
Well, doesn't that come from that recent trial of recruitment maneuvers in ARDS that used the incremental PEEP? I can't remember the name of the trial. It's a couple of years ago.
Yeah, the art study, no,
RT, right?
JAMA, yeah, JAMA, September 2018, I think. Yeah, that showed an increased mortality associated with the use of titrating PEEP upwards,
Right.
and recruitment maneuvers, a complex intervention with a worse outcome compared to standard care.
Yeah.
So that is the 5 statements for ventilatory strategy by the Surviving Sepsis campaign. And it doesn't seem like a whole lot has changed in terms of those recommendations. And of course, understanding what those recommendations are. But any thoughts of things that are missing from those recommendations, or things that you would add if you were adding to this recommendation list?
There are a number of different ways to titrate PEEP. None of them have much support, but they recommend one which has no better evidence than anything else. And I wondered whether it's worth discussing the different ways PEEP could be titrated. Obviously, people use the PF tables or the PEEP to PO2 tables for titration. Generally, and they've been historically, nothing's been better than those, but there's no evidence that they're any better than guessing anyway. They were some couple of years ago, we tried to find out where that information came from, the original table, and it was made up by a group of people who were obviously experts in the area, but they had no evidence to support their PEEP of 10 and FI2 of 0.6. There was no evidence to support that. It was just what they did. So we use a hysteresis curve to titrate PEEP often, using a number of parameters, using the Hamilton tool occasionally, and we often use an esophageal balloon in difficult cases. But it'd be nice if the recommendations made some pronouncement about the utility or otherwise of those.
I think those are interesting and amusing comments, Ross, because I was going to say just previously regarding the recruitment maneuvers that I don't do them routinely, but I often do a recruitment maneuver at least once, because we do have the Hamilton ventilators and we do have the PV curve. And oftentimes early on in patients I have with ARDS, if they're paralyzed and not making respiratory effort, I'll do the PV curve in an effort to try to identify a lower inflection point. And as long as I'm doing that, I do a recruitment. I do a pause at 40 or 45 centimeters of water for a period of time. And again, I'm aware that maybe searching for the lower inflection point is not the holy grail for optimal PEEP, but none of the prior proposed techniques, including cardiac output measurement or the tables, have ever been proven to be the one gold standard. So I wish we knew.
Graeme, I was going to ask you, there are quite a few ventilators that I'm aware of that do have those stair stacking PEEP technologies built into it under their recruitment envelope. And do you find that it's available in most ventilators?
I think everybody has some toys that you still have to have some knowledge, right? Because I still think in the wrong hands, these toys are very dangerous. I've done a lot of work with this in the past, so I have my own bias on this. I like what Ross mentions is looking at the lung elastance hysteresis curve. This has already come from Keith Hickling. What he thought, looking at lung closing pressure, to me makes good sense, especially if you're looking for recruiters versus non-recruiters. Yeah, I think there's a lot of things we can do. I don't think anything is very clear. Even like TPP is it has a lot of technical skills as well, right? So I think we're still looking for the right tools.
I have a question related to proning. Are you guys using proning as a regular means, or is it only really for those who seem to have the basilar collapse, as Ross had pointed out earlier? Or is, I think Gattinoni had mentioned the labor intensity of proning early on in some of his statements. What are you guys doing in terms of proning? Is that a standard practice for these sorts of patients with basilar collapse?
Most of our patients, if they're hypoxic enough on the ventilator, and we think we're treating ARDS, will get prone, to get a trial of proning. Often you can identify the patients that you think are probably going to respond and the patients that may not respond. And in my experience, in our practice, we still, even if we're not sure that they're going to respond, we'll still do a trial of proning. But it's, compared to when I was working in the US, proning a patient here is a lot easier than proning a patient in the US. Our patients generally have BMIs in the low 20s, and flipping a 60 kilogram patient is very different to flipping a 120 kilogram patient.
No back problems, Matt. You can do it with one arm, right?
Well, I don't. It's the nurses that do the flipping anyway.
Volunteers.
It's an interesting question, and I mean I feel that we are probably practicing exactly the same way that Matt is at this point, and I think we're talking about the COVID patients, but even if we're talking about ARDS from any cause, right now we're pretty much giving almost everybody that we can a trial of proning, and unlike Matt's situation in Singapore, we do have some patients with BMIs above 50 or 60 that just technically we can't. But once we got the rush of patients with COVID-19, we rapidly ran out of the Arjo Huntley rotaprone bed, which we previously used in almost everybody. So now we're doing manual proning. And we don't do CT scans on the COVID patients unless we absolutely have to. So we don't know what their precise anatomy of their lung involvement is. We give them a trial, we see if their gas exchange improves, and if it does, we keep doing that. And we use staff to do that, usually an average of 6 persons to turn a patient.
Sure.
Well, we have a range of patients. Some have BMIs of 40, some in the 20s. And we try to offer them, all of them, the prone if they are hypoxemic, and whether or not we can predict that they are going to work based on the available radiology imaging, we'll give them a trial. And we did find that it's quite helpful in all of our ARDS and perhaps some of our COVID, although I haven't looked at the data carefully yet.
Our experience tonight is probably the same for you guys in San Diego, is really nobody goes on ECMO without a trial of proning.
That's certainly true for us, yes.
Okay, gentlemen. Well, this has been very informative. I think where we landed is these recommendations still make sense. We would add a few additional items if need be, but it's not a bad set of recommendations considering 4 months into it since it was released, and they all seem to.
Well, I would, I think we've talked about this before, Steve, but I think that we're continuing to learn that some of what we probably now consider to be the fundamentals of our management of severe hypoxemic respiratory failure patients that are now based on some of the evidence-based studies that have accumulated over the last 20 years don't need to all be thrown out the window just because we have a novel coronavirus causing the ARDS that our patients are experiencing. So yeah, there are some different things about it, but the basics still apply, and this has been fairly instructive going through this to really reinforce to us that a lot of the things we've been doing for a number of years are still applicable in the current pandemic.
Okay, well, I think that does it for this session. Appreciate everybody helping walk through the guidelines, and I look forward to our next Ventilation Matters podcast. And in the meantime, everyone breathe easy. Okay.
Thanks, Steve.
All right.
Thank you.
Very helpful.